Hello, I'm Marielle Jessup. I'm a professor of medicine at the University of Pennsylvania's Perelman School of Medicine in Philadelphia. Our goal today is to talk about heart failure and what our current state of knowledge about the best way of treating these patients. Our learning objectives for this session are to initiate and modify guideline-directed pharmacologic treatment for the management of outpatients with heart failure, implement device therapy in appropriate outpatients with heart failure, and identify unmet needs where we don't know what to do for these patients and gaps in the management of outpatients with heart failure. That's what we hope to gain by reviewing this information. Heart failure is a huge epidemic in our country and in most countries around the world. Currently in the United States, it's estimated that there are about 6 million adults with heart failure, and this incidence is expected to increase. It's the number one reason why patients over the age of 65 are hospitalized. And it's responsible for countless deaths, and either as the primary cause of death or as an associated mortality. And it is also responsible for millions of office visits and emergency room visits. Most importantly, aside from this morbidity and mortality, it's costing our country billions of dollars. In 2012, it cost over $30 billion for the management of heart failure alone. About half of that is related to hospitalizations. Therefore, it's not unexpected that our government is looking at ways to reduce hospital admissions. After saying all those grim statistics, the good news is we've gotten better at managing heart failure, so that between, say, 1950 and 1969, and the most recent cohort of 1990-1999, we've actually done a better job, both in men and in women, so that survival overall is improving. Women tend to do better up until when they're very old than men, and that probably reflects the etiology of heart failure. Nevertheless, heart failure is a serious diagnosis, and after a first admission with heart failure, the actual chances of surviving are worse than most cancers in this country. And that's a sobering statistic, and it's something that I stress to the patients a lot. This is a serious diagnosis, and it requires a fight, just like people talk about fighting to survive cancer. We have to fight to survive heart failure. And more importantly, in our age, in our country, the prevalence of heart failure is expected to increase. Part of that is good news. Patients aren't dying from myocardial infarction anymore. They actually go on to live, and that common final endpoint may be heart failure. People aren't dying suddenly anymore because we've got effective management strategies, most importantly, a defibrillator, and so that those patients may go on to have a myocardial infarction and to have heart failure. And so, more importantly, we're beginning to understand that there is a genetic and racial difference in who's getting heart failure, so that blacks and non-Caucasian whites are developing a much higher incidence of heart failure. And as I said, women in older age are developing heart failure at a very alarming rate. And as a result, as our population ages in this country, heart failure is on the rise, with costs that are expected to rise dramatically. So something has to be done, because the costs associated with heart failure, if they increase as they're projected, are going to be non-sustainable for our country. So one approach is to really develop guidelines to help clinicians manage heart failure. I was honored to be part of the 2013 publication of the American College of Cardiology and American Heart Association guideline for the management of heart failure. In fact, an update of this guideline is being developed as we speak. And as all guidelines, and certainly the ACC-AHA guideline, was developed after extensive review of the evidence. This is evidence-based recommendations. And the evidence was reviewed from the previous guideline all the way up through April of 2013. There is a search for the evidence and publications from a wide variety of resources, including PubMed and Cochrane and quality reports, and other documents are obviously looked for, including publications of big randomized trials. So here's a brief overview of what the ACC-AHA practice guidelines have recommended. First, they have starting in 2001, as a matter of fact, there was a new classification of heart failure. So for many, many years, we've used the New York Heart Association functional classification, 1 through 4, with Roman numerals. And the idea is that when we talk about a patient, we can say they either have no symptoms throughout their daily activity, so that's a New York Heart Association functional class 1, and then there is a patient who is NYHA class 4, that is the patient's having symptoms at rest. But the ACC-AHA Guideline Writing Committee felt that it was really important to describe patients in a more explicit way. So for example, somebody might come into the hospital with NYHA class 4 symptoms. We might put them at bed and give them IV diuretics, and they'd be NYHA class 3 in the morning. And yet just by giving diuretics isn't going to change the natural history of disease. So the argument was that we needed a better classification, and so we described the stages of heart failure just like there's stages of cancer. So stage A is that patient that's at high risk for heart failure, but without structural heart disease or symptoms of heart failure. Who are those patients? Patients with coronary disease, patients who have longstanding hypertension, patients who have diabetes, patients who have been exposed to cardiotoxic drugs such as chemotherapy. So those are the high-risk patients, stage A. Stage B are those patients who have structural heart disease, but without signs and symptoms of heart failure. Interestingly enough, this group of patients is probably the greatest out there. Patients with left ventricular hypertrophy or silent valvular disease or asymptomatic left ventricular systolic dysfunction. That's stage B. Stage C are the patients that we all think of as heart failure, those patients that have both structural heart disease and current symptoms of heart failure or prior symptoms of heart failure. So that you can't go backwards. Once you have heart failure, you can't go back to stage A or stage B. You're always going to be a stage C. And stage D are those patients with refractory heart failure, requiring specialized interventions like transplant or ventricular assist device. So that the NYHA classification can be used to describe stage C and stage D. We also tend to categorize patients with heart failure based on their ejection fraction. And the broad categories are those patients with HFrEF, heart failure with reduced ejection fraction, and in general we call that patients with an ejection fraction below 40%, and HFpEF, heart failure with preserved ejection fraction, where patients have an ejection fraction over 50%. Old names for HFrEF was systolic heart failure, and HFpEF was diastolic heart failure. But we've come to realize that there are other classifications, such as the patient with borderline, 41 to 49%, and the patients who once had a low ejection fraction, and now it's better. So we're going to have to come up with a better nomenclature. So let's talk briefly about management. So first, we have to find out why somebody has heart failure. Do they have coronary disease? Do they have uncontrolled hypertension? Do they have valve disease? And then we have to plan our treatment strategy. And certainly we divide it up now by HFrEF, which is basically guideline-directed medical therapy based on lots and lots of clinical trials, and the management of HFpEF, which is the less guided by trials. And we're influenced by what our goals of therapy are, and some of that matters depending on what stage. So certainly stage A heart failure, which means they've never had symptoms and they're at risk, is to prevent them from developing heart failure. And we're not great at preventing heart failure, although there are some specific patients that we know how to prevent. Stage B heart failure is to prevent the development of symptoms. That's our goal. And stage C is to control symptoms and prevent mortality. And stage D, we may not be able to prevent mortality, but maybe we could delay it. Now, our recommendations for therapy with HFpEF, as I've already said, there's very few trials that have convincingly shown we can alter the natural history. Certainly, we have not had a single trial show us that we can influence mortality. We know we can give diuretics if there's fluid retention to make patients feel less breathless, and there's lots and lots of reasons to control their blood pressure. These patients in particular often have coronary disease, so we need to do some assessment to make sure that not only are they not ischemic, but if they are ischemic, whether revascularization in some way would help. And patients with HFpEF are particularly prone to have atrial fibrillation, so we need to look for that actively and treat them, particularly to prevent stroke. There are other drugs that may be used. One trial with using an angiotensin receptor blocker was shown to decrease hospitalizations, as well as an MRA, a mineralocorticoid receptor antagonist. There's not much else that helps these patients, but getting them out and having active physical therapy or cardiac rehabilitation is a great idea. The good news is in patients with HFrEF, we have lots of drugs that have been shown convincingly to reduce mortality, including angiotensin receptor blockers, ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists. And there's been a number of important publications showing the remarkable progress we've made in reducing mortality. And a schema might be that first you take patients with HFrEF who are symptomatic, they've had heart failure, and almost everybody should get an ACE, or if they can't tolerate an ACE inhibitor, an ARB and a beta blocker. And we add the drugs a little at a time to give patients the life-saving benefit of using an ACE and a beta blocker, or an ARB and a beta blocker. And then we have to sort of individualize. So for patients who are still volume overloaded, they need diuretics. For patients who are self-described African Americans, there's very good data showing a combination of hydralazine and isosorbide dinitrate. And certainly for patients that are able to tolerate it with reasonable renal function, adding an MRA or aldosterone antagonist. There's two new drugs that are out there that have just been approved that are very exciting, including a drug called sacubitril valsartan. We know it maybe in the past as LCZ696. That's just been released in the United States and has been shown convincingly in a patient population to, instead of ACE or ARB, to markedly reduce mortality, hospitalizations, and heart failure mortality. Avabradine is another drug that was just released in this country and has been shown convincingly to reduce hospitalizations and mortality. And even iron supplementation has been very, very effective to improve quality of life. And so there is a little bit more complexity to managing patients with HFrEF, and you have to think about the possibility of atrial fibrillation in these patients. And we know that some drugs are actually contraindicated, so that we wouldn't want to use an ACE and an ARB and an aldosterone antagonist in most patients. We don't want to use most calcium channel blockers because they're negative inotropes. And we certainly don't want to use drugs like NSAIDs, sort of things like Aleve and ibuprofen. And we there isn't even any good data to use a drug like a statin unless if you're giving it only for heart failure. Now, besides drug therapy, we have great data for reducing death with implantable cardiodefibrillators, or ICD. And we have two very important trials looking at those patients with ischemic heart disease and low EF, as well as patients with both idiopathic and ischemic. And really everyone who is expected to live longer than a year and is stable with low ejection fraction despite good medical therapy, an ICD should be considered. And perhaps over the last decade, a really exciting therapy has been cardiac resynchronization therapy or biventricular pacing. We often call it cardiac resynchronization therapy, where in patients with conduction abnormalities, a pacemaker resynchronizes the contractility of the left ventricle. The morbidity and mortality reduction with CRT has been truly phenomenal, especially because it's been added on to patients who are already on all the therapy I just showed you. And there is an astonishing improvement in cardiac function shown with CRT, and it really has demonstrably, patient over patient, shown how much cardiac function can really improve with just this pacing. It's gotten kind of confusing about who to give cardiac resynchronization therapy. It used to be just anybody with a QRS over 120 milliseconds. And now as we do more studies and look at more analysis, it's pretty clear that the QRS needs to be widened about 150 milliseconds, and left bundle branch pattern seems to be the best of the patterns. And here's some good news for women with heart failure. It seems that women respond better than men to this therapy. That's not pretty typical in most medical therapies. So if we take all of these therapies in HFrEF, both the medical therapy and the benefit of ICDs to prevent sudden death and CRT to improve remodeling, we've had a remarkable reduction in mortality in this patient population. So with all that, what still don't we know? The problem is that heart failure is increasingly common as our patient population ages, and there's a rising prevalence that we still have to get our arms around, and it's associated with major morbidity and mortality. We really don't know what to do to, beyond mortality benefits, what's the best strategy to improve health-related quality of life? We've got to figure out what to do about the elderly, women, and underrepresented minorities who have a higher prevalence of HFpEF. We have to understand how to manage patients who have comorbidities such as arthritis or renal dysfunction, because it really impacts how we manage them. We've really got to learn how to incorporate ivabradine and sacubitril valsartan into our algorithm of care, and that's going to be fun and a challenge over the next few years. And we've got to figure out how to help patients take all these medicines to improve patient adherence. Despite our great advances in the management, particularly in the patient with HFrEF, there's so many things that we still don't know, and we have big evidence gaps. We don't understand how much sodium restriction we need to demand of our patients, and boy, do they really not like restricting their sodium. We need better studies to understand how important that is. We need to understand and learn how to manage the patient with cardiorenal syndrome, meaning the patient with both heart failure and renal insufficiency. So many of the drugs we use are impacted greatly by renal insufficiency. We have to understand how to use biomarkers to optimize medical therapy. Is there an advantage of measuring these drugs serially to more personalized care for our patients? I've said several times we really need to understand how to manage patients with HFpEF, heart failure with preserved ejection fraction. There has to be something more besides just managing their blood pressure, although that's certainly important. Probably most importantly, we need to understand better processes of care, especially as we transition patients from the hospital to home. If we're really going to make a dent in heart failure readmission problem, then we have to understand what it is that can prevent the patient from coming back to the hospital so soon after just leaving. And if we could prevent heart failure, that would be the best of all. We know that if we can control hypertension, if we can really get patients' blood pressure under better control, we can probably reduce heart failure by 50%. And even if patients have left ventricular dysfunction, it would be nice to know how to prevent them from developing symptoms. There has to be a way that we assure that patients get the same care no matter where they live, no matter what hospital they're in. For instance, in one study looking at a Get With the Guidelines program from the American Heart Association, less than a third of eligible patients were getting a mineralocorticoid receptor antagonist. And we still know that about a quarter of patients with heart failure are re-hospitalized within 30 days. We've got a lot to do. Heart failure management can be complex, but if you look at the patient in front of you in your office and say, are they on the things, the drugs and the therapies and devices that we know to reduce morbidity and mortality, that's the first step. Don't get overwhelmed by the complexity. It's simple with one patient at a time. So guideline-directed medical therapy in HFrEF is lifestyle modification, an important and life-saving combination of pharmacologic therapy. The burden of heart failure is enormous with numerous gaps in management, but there's lots of hope for the care of patients with heart failure.